My name is Dr. Zelda Gerson, and I'm a second-year pediatric intensive care unit fellow at Mass General Hospital for Children. Today we'll be discussing cuffed endotracheal tubes, their care and management. I'd like to start by discussing airway anatomy and the most important structures needed for intubation. Here you can see the base of the tongue, epiglottis, false vocal cords, true vocal cords, and arytenoids. There are important differences between the adult and pediatric airway that we will discuss now. The adult airway is larger, the tongue is less obstructive, the airway is more centered, the head is proportional to the body, and the narrowest point of the airway is the cricoid ring or the vocal cords. In the pediatric or child airway, the airway is smaller, the tongue is larger, more superior, and obstructive. The airway is generally considered more anterior and superior. The head is larger compared to the body, and the narrowest space is the subglottic space or the area below the vocal cords. There are two types of endotracheal tubes that are most commonly used: the cuffed endotracheal tube and the uncuffed endotracheal tube. Sizes range from 2.5 through 7 millimeters internal diameter. Sizing of cuffed endotracheal tubes. A quick formula to size an endotracheal tube is as follows. For an uncuffed tube, we generally consider age divided by floor plus 4. We go down by half a size for a cuffed endotracheal tube. For example, an uncuffed tube, an 8-year-old boy, would have a size 6 endotracheal tube. For a cuffed tube, it would be 5.5. For the depth, a simple way to remember a general depth of the endotracheal tube insertion is 3 times the size of the endotracheal tube. In our example, if you were using an uncuffed tube, that would be 18. For a cuffed tube, that would be anywhere from 16 to 17 centimeters depth. Intubating with a cuffed endotracheal tube. Before intubation, check to make sure the cuff inflates properly. Make sure the patient is adequately sedated to avoid airway damage during the intubation. Pass the endotracheal tube through the vocal cords with the cuff down. Slowly inflate the cuff with 5 to 10 cc's of air. Secure the cuffed endotracheal tube as you normally would. When intubating with a cuffed endotracheal tube, we always make sure the cuff inflates properly. After ensuring that the cuff is inflated properly, we deflate the cuff. Intubating with a cuffed endotracheal tube is a lot like intubating with an uncuffed endotracheal tube. I see the vocal cords. We are through the vocal cords.
Inflate the cuff. Connect the CO2 detector if available. Confirm color change. Bag, please. Listen for bilateral breath sounds. And listen over the epigastrium. Once the tube's inserted and placement has been confirmed, the tube must be secured. Some people use tape. You can use commercially prepared devices if available. In this case, I've split a piece of tape. I'll secure it to the patient, then wrap the other piece around the tube. So that it's secure.
Measuring intracuff pressures. The respiratory therapist will measure cuff pressure following placement of a new endotracheal tube and then at least every 4 hours. We generally inflate the cuff with the minimal amount of air needed to seal the airway and ensure adequate tidal volumes. Cuff pressure should generally be maintained greater than 20 centimeters of water and less than 30.
It has been secured. Now we want to be sure that the pressure in the cuff is not excessive. I'll use a manometer with a syringe, connect to the tube, and inflate to a pressure greater than 20 but less than 30 centimeters of water.
Management of high cuff pressures. Decrease the cuff pressure to 30 centimeters of water by withdrawing a small amount of air from the balloon with a 10 cc syringe. Listen for the presence of an air leak around the cuff during a positive pressure breath. If an air leak is present, add just enough air to seal the airway. Measure the cuff pressure again. If pressure remains greater than 30 centimeters of water, evaluate the position of the tube in the airway and reposition if needed. Consider other possible cause of high cuffed pressures, or consider changing to a larger endotracheal tube. Management of high cuff pressures. Decrease the cuff pressure to 30 centimeters of water by withdrawing a small amount of air from the balloon with a 10 ml syringe. Once that's been done, listen for the presence of an air leak around the cuff during a positive pressure breath. If an air leak is present, add just enough air to seal the airway. Measure the cuff pressure again. If the pressure remains greater than 30 centimeters of water, 1. Evaluate the position of the tube in the airway and reposition if needed. 2. Consider other possible causes of elevated cuff pressures. 3. Consider changing to a larger tube. Management of the cuffed endotracheal tube. If the depth of the tube needs to be readjusted, suction any secretions that may have collected above the cuff, remove all air from the cuff, reposition the tube to the desired depth, reinflate the cuff. Suctioning with the cuffed endotracheal tube is the same as suctioning with an uncuffed endotracheal tube.
Suctioning a cuffed endotracheal tube is the same as suctioning an uncuffed endotracheal tube. Insert the catheter into the airway. Withdraw, applying intermittent suction for no more than 15 seconds.
How to extubate with a cuffed endotracheal tube. 1. Always suction pooled secretions above the cuff. This reduces the incidence of aspiration and ventilator-associated pneumonia. Take down the cuff by removing the air from the cuff. Check for a leak. If there is no leak, the patient may need a dose of steroids to decrease airway edema. Pull the endotracheal tube as you would an uncuffed tube. If possible, have steroids and racemic epinephrine available for post-extubation stridor. Extubating with a cuffed endotracheal tube. 1. Always suction pooled secretions above the cuff. This reduces the incidence of aspiration and ventilator-associated pneumonia. 2. Take down the cuff by removing the air from the cuff. 3. Check for a leak. If there is no leak, the patient may need a dose of steroids to decrease airway edema. 4. Pull the endotracheal tube as you would a cuffed tube. If possible, have steroids and racemic epinephrine available for post-extubation stridor. Complications of using cuffed endotracheal tubes. Prolonged overinflation of the cuff can cause pressure necrosis of the tracheal mucosa. This mucosal injury can lead to failed extubation, post-extubation stridor, and subglottic stenosis. This is why we take extra care to make sure the cuff is inflated with the minimal amount of pressure needed to seal the airway and never exceeding 30 centimeters of water. Take-home points. Cuffed endotracheal tubes are better for the pediatric patient. They are better for optimizing pulmonary mechanics by creating a seal that avoids leaks and facilitates mechanical ventilation. This decreases the number of endotracheal tube changes and overall decreases the rate of post-extubation stridor and long-term airway damage. Here are some references for further reading. If you have any questions, you should consult your respiratory therapy team as well as your attending physicians.